Welcome back to Rebranding Menopause. We're so excited to have you here. We are here with Dr. McNally today from Northwell Health, who is a gynecologist who specializes in menopause management and care. And I'm here with Dana Persico, our co-host, and Sharon Grasso. So we could not be more excited to have you back again.
Yay!
Yay!
She is the superwoman of menopause care.
She is. On Long Island, she's it. We're really happy to have you, and I'm thrilled actually that you are managing my menopause symptoms and care. So I'm in really good hands, and
do you know what Ingrid told us this morning?
Tell me.
She already feels better.
I slept throughout the night. I slept until 6:30 this morning, which never happens. Wow. And I just feel like there's a little pep in my step.
You look fantastic.
What is typically the window? Like for when someone starts their creams, their treatment, what is typically the time frame that you start to really see and feel results? Usually
for women, it can vary when the symptoms or things that we're tackling start to shift in a positive direction. But we like to give it 4 to 6 weeks because your body kind of sets a new level. And it really depends on if you're starting hormones when you're perimenopausal versus menopausal.
Right. That's another thing I wanted to talk to you about. So I'm 56 and I just started with the little patch,
the estradiol patch twice a week. Water resistant.
Exactly.
Oh, so how do you do twice a week? So how do you split that?
So to make it easier, we
That's
usually
not a dumb
do.
Question, right?
It is not. So you could set a custom on your phone where every 3 days you change it, or you could do it Monday, Thursday, Tuesday, Friday.
Yeah,
kind of a 3 to 4 day window.
Got it.
Twice a week.
So now, and then I'm taking the progesterone at night.
Correct.
And now, how long before? Like, could I stay on this forever, or will I go up a little bit in dosage? And also, because I haven't had my period in a year, is it like not? I don't want to say too late, but is it going to affect me differently than if I started earlier?
So these are great questions. We call it in medicine the timing hypothesis. The time in which you start hormonal therapy really helps. So the closer you are to that transition time, probably the better for you from the cardiovascular health, your bone health, probably your cognitive health, your vaginal health. So you're right on target within that year or so. Some women start in the perimenopausal period, and so your doses, your treatment really have to be individualized. But I think what's really important for everybody to know is when we say menopause, it's defined by a woman that has a uterus with no cycle. And that's not fair to women that do not have a uterus.
Right.
Correct. And for those that have symptoms, quote unquote, sooner. What do I mean by that? Your symptoms can start for some women prematurely. And so if your cycle stops before the age of 40, that is premature. That is related to ovarian insufficiency because your ovaries make your estradiol and your progesterone. So when it's symptomatic or things, and we had talked about when do you seek help? When something feels off, you've got to seek help. And whether you start with your internist or your GYN, it doesn't matter, but it matters that you get some answers.
The other thing that I wanted to just bring up quickly is that, we have been getting literally hundreds of DMs on this subject. I mean, Dana's video just got like 800,000 views. It's really incredible that people want to know the answers. Yeah. But we do see a lot in the comments where, oh, my doctor said I can't do that, or they don't recommend that. Then you need a new doctor. Right. Would you agree?
If you're not being heard and being listened to, which, as you guys know, your parents are two totally separate things.
Right.
There may be a medical indication why it's a hard stop, but we actually have a checklist, kind of that green light, yellow light, red light of who qualifies. And for somebody to say in any walk of life, you cannot do that. Well, okay, tell me why.
Right.
Let's talk to it in a patient-centered way. And so if you are that early menopause patient or premature, right? Premature would be between the ages of 40 and 44. Anything after 45, we consider normal.
Okay.
And I use that in quotes because whatever normal is now.
What would be, and I know it's not different for everyone, but what would be an absolute hard stop? If a patient came to see you wanting hormone replacement, who is that patient that is absolutely not a candidate? Is it, what is it?
So at least in current iteration with data, for a patient that is undergoing estrogen receptor positive, progesterone receptor positive breast cancer, that systematically, again, we want to make sure when we talk about hormone therapy, it's not just your system, your patches, your pills, because you could have local treatment, but that would be a hard stop. Or somebody that has active blood clots, because estrogen can increase. Those are two that just come to mind off the top of my head, but those would be hard stops for me and most.
How do you determine, because blood clots is such a, you maybe wouldn't know that, right? So as such a respected physician and expert in your field, what do you screen for that? Do you ask if there's a history? How would I know if I'm that person?
So there is an inherent risk for medications across any discipline. But for family history, prior history, that's why, and we've talked about this before, getting that detail about what's happening in your family, not just your immediate siblings, but parents, grandparents, if you know it, is helpful.
So people shouldn't be afraid of this. There are ways to know who's a good candidate, who's not, and they should come in and ask the questions, not just because they think they heard or they might not be a candidate. There are ways to make sure it's safe for more people than we think.
Correct. And also, what are the complementary or integrated things that are not going to be hard stops that may give you some benefit?
Sure. Now, that's the other question. A lot of doctors aren't well versed in, a homeopathic way. So what would you suggest to someone? I know you probably are a little bit more open to that than most, but for the regular person going to their gynecologist who wants to go through this the natural way, and a lot of people do, and some people don't have symptoms, what would you suggest for them?
To have the conversation to start, because there may be things that they're doing or want to do that's in the purview that provider is comfortable. So first, it's an open dialogue. The area of complementary medicine and functional medicine, there are some nuances, but I think for a woman to get what she needs to be, as we say, in a comfortable space. So that area of medicine can be really helpful for them.
Yeah. But I mean, as far as the functional, like I said, like for instance, I just showed Dr. McNally the bag full of vitamins.
It was a large bag.
And supplements that I'm taking, because I literally will see this and I'll be like, that's me. I'm ordering it and I'm taking it. So
I
she's
bet
like,
you
you're
don't
taking
need,
way too much.
I was going to say, you probably have 2, maybe 3 that would benefit you, and the rest, would you have
Right,
did
like
you
the
come in with
biotin.
20?
I think I lost track at 15.
Right. That's what I'm saying. So someone like me who wants to go through everything naturally before I just started my hormone replacement therapy, I could be doing damage or a little bit, something that's maybe not as healthy for me with taking all these supplements.
Well, that was my other question. So, some of these natural, and I love a natural path when you can do it, but they're not FDA regulated, a lot of these supplements, right?
Right.
And can't they be, can't think of the word I'm looking for, where they're interacting wrong with something you may prescribe?
Right, a contraindication between something that, there's really not
That
any...
was the word I was looking for.
Yeah,
Thank you, Dana.
There's no safety dossiers that are printed for some of these supplements that are out there, and they're everywhere.
I'm not saying some of them are not great, but when you're seeking out something like to be under your care and to actually have the patch, sometimes in combination with supplements that you're just grabbing because they sound good can be counterproductive, no?
For the estrogen patch, specifically if we're talking about that, there usually should be a very nice combination where it shouldn't. But to the point is that our bodies are smart and they're going to absorb what we need. So anything that's extra, we really excrete, whether it's any which way. So I think it's important that supplements can be really helpful, especially when there's a deficiency.
Right.
But more may not be better.
Right.
And if you feel great taking something, wonderful. If you don't notice a difference, then it's always good. And I like to use the analogy when people are introducing foods to children, or if you're doing an allergy testing, start slowly. Take everything away. Hit restart, and then see what makes the difference.
Right. I mean,
great advice.
Would there be maybe like 2 or 3 supplements that you could say overall, not for everyone, of course, that overall would be beneficial for someone in menopause that is using the patch and
progesterone? And many women are deficient in vitamin D. Right. So we're talking about bone health, and then that kind of ties into calcium. And we want to be very cautious. A lot of things that we're saying have a big asterisk. Talk to your provider, because kidney disease, other cardiovascular risks, thyroid, parathyroid, all of these things get tied in together with your balance of actually calcium. But in general, vitamin D deficiency is pretty common amongst women. We all should be wearing sunblock on our face every day and our face creams, so we may not be getting as much. So that's something you could check a level and supplement accordingly. If you're eating a true balanced diet, I
don't know anyone who's eating a true.
I think a lot of us try.
We
We
try.
try.
Right. So I'm guilty as charged. I try.
Right. Try your
try.
best.
So a multivitamin really has a lot of the stuff. And that's where, for women of all ages, is prescription better? So I would challenge people, look at what's being prescribed, especially a lot for prenatal vitamins versus over the counter. It's very similar. So the cost effectiveness of this on a regular basis is a big thing. So I would say your vitamin D, calcium, your multivitamin. And I have to say anecdotally, and there is some literature to support it, magnesium at night can be very helpful for sleep, relaxation, and actually migraines.
Interesting.
So that kind of tension, smooth muscle, and we've talked about a lot how hormones change. Those are the 3 go-tos that I make sure everybody at least discusses and gets some more information about those.
Yeah, I think that once I started taking magnesium, I felt like my leg cramps went away.
Oh,
I
yeah,
had
they say that.
Yeah,
They say it's
and I also have
incredible.
the spray magnesium.
Yes.
The topical. It really works.
I have it. I haven't tried it yet.
Yeah, you have to use
I
it.
have
It's
a
great.
question, which is maybe completely off base, but it's such a common thing now. Hormone replacement with Mounjaro, Ozempic, is there anything contraindicated? Does it change in any way the way our bodies accept the hormone replacement, or is there no connection at all?
That's a very good point in terms of body mass index and absorption. That's why we kind of think about it, especially with the timing hypothesis. You start low and then you build up as needed based on symptoms. So a lot more data is going to come up about the benefits actually of some of the medications, injectables that people are doing for their metabolism, then the absorption and the benefits of the hormone therapy. So more to come about that, but that's a great point and a great question.
It's just so commonplace now. So
Correct.
I think that it almost needs to be discussed as part of any protocol that we start, because there's so many people on it.
Correct. And the interactions right now are not in a negative way. So I think there'll be some positive things that come out of that for women's health.
So
And is
many
it fair to
positive
say that
positive.
that applies to the prescription FDA approved weight loss injectables? However, the compounds, once again, because they are a
Not controlled.
formulation of someone's idea, right? It's
Yep.
based on someone's idea of what works. They're saying that looking down the runway, that there may be concern that the compounds may have implications that people are not really being told about. So is that something that you're hearing in the medical community that people need to be aware of?
Right. And exactly. It has to be something that is really monitored, because it's not necessarily only injectable medications that's gotten a lot of important good press for people's health, but also some of the medications that are oral that have been used in the past can also be helpful. So to that point, we want something that's regulated. And listen, I have patients, and this is why the detail that you give your physician or your provider is so important, that are getting medications from pharmacies in different countries.
Oh my God, I hear that scares the life out of me.
So again, this is not about what you need to do, what you're not needing to do. I understand there's a lot of difficulty with insurances and getting things that people do need. I am on a quest to get the black box warning for local estrogen gone, that it should be safe. The ways that we are going to interact with the newer medications that are for hot flashes, insurances are not covering it. So again, that's a whole other topic. I know we want to talk about the finances of it, but in general, tell your physician, tell your provider, please, what you are taking, whether it's prescribed, whether it's compounded, because all of that compounds into how your health reacts.
Including vitamins.
Correct.
Yes.
Right. It's a whole management. It's a whole big thing.
Yeah, and when you
It's a
talk
full-time
about the
job.
financial aspect of it and you talk about access and people purchasing outside of the U.S., because obviously healthcare is a very hot topic here in the United States, it's very controversial. There is, we've talked about it, there is a bill, it's a Senate bill that was introduced in 2024 that is the Advancement of Menopause Care Act. Hopefully, it is doing very well. I think now with the change in the Congress, actually this week and next week, we're going to have everybody in place for their new positions in the different committees. It's great to have someone like you on board because we would really like to know if you would be willing to. I'm sure Northwell and your team members are waiting for something like this to happen. It will, if it gets through all of the lawmaking process, it will improve the awareness for healthcare workers because it'll become part of their workforce development training. It'll also expand finances that are going to be appropriated. And again, we know it's right now this new administration is looking at tax savings, but when it comes to healthcare, it's a really big initiative for this new administration. So hopefully we can talk further about menopause because it is a diagnosable condition for many women, and we went over those big numbers before, how many women are affected. So I'm glad that you're supportive of that and that maybe we can take it to the hill someday soon.
Listen, anything that's going to help women, I am on board for.
Right.
And think about it. When you're potentially making less money than certain male counterparts, and then your medications are costing more, then you are not sleeping because you're not getting the medications or treatment or the access. And it, to your point, starts with the education. Empowering women, empowering patients, and then educating our providers to say, this is real. So all of these factors are going to make a huge impact. So if I can get my patients' medications down to $30 a month as opposed to $500,
Right.
and they can sleep and be more productive, amen.
Right. And
Amen
to
to that.
your point, I'm so happy to hear everything that you say. All of us are. I recently, again, I've been on HRT, hormone replacement therapy, for almost 10 years. I recently found out that the estradiol patch is covered by insurance.
Yes.
Most insurance. I didn't know that. I've been paying out of pocket for the compounded version all of these years. So
I have chills.
information- I know. And so,
Yeah.
it was
$5 for me.
yeah, it was really wonderful to find out that there is been advancement and there is access available, but we do have further, there's work to do.
Absolutely.
So, it was good news. We want women to know that.
Yes.
Everyone, you can get it covered under your insurance.
And the estradiol, the micronized progesterone, which is a really nice combination that many of us use as a starting point, because there's different progesterone combinations, different dosing mechanisms, but these two are bioidentical. It's what your ovaries made before they became shriveled up.
Little reasons.
Before they went bye-bye.
Bye-bye.
So, and stay tuned because there's going to be really great information coming about a call to action that this podcast is going to be putting out to women all over the United States, not just here on Long Island, where you're actually going to have an opportunity to get your request for the expansion of this act right to your representative and let them know that it's important to you. And we're going to make it so easy, a couple of clicks, 2 seconds, and you're going to have a say. Your voices will be heard.
That's so important. 'Cause
Yes.
people don't
Love
know
it.
where to
Nina.
go.
Yeah.
She's a badass, this one.
Well, we got to make those lawmakers really get it.
You know, and to that point, how many medications are approved for male sexual changes
Right.
Yeah,
versus
what's up with
women?
that?
I know. We'll
Right.
get there.
Right.
There are some on the market targeting premenopausal, perimenopausal women, right? And when you're looking at data, again, our jobs are to make sure we're educating women. There was a very big workshop, straw data, looking at the stages of reproductive aging workshop. So where you are when you miss a period versus missing 5 is an early transition versus a late. These are the times, the changes, advocate for yourself. When you're on that spectrum of transition, it really could be a year, 10 years, 5 years. It varies from woman to woman.
Doesn't it vary also between race?
Yes.
Like different races.
100%. And so for some women that are of Asian descent, particularly Japanese women, their vasomotor symptoms, let's talk about that, your hot flashes, they may have them for about 3 to 4 years, where Latina women may have it for 9 or 10.
Yeah, that's what I heard, 9 or 10.
And then also, how
That's
do
why
we
they're
say
spicy.
it?
Yeah.
But also, how do we describe to our providers or our doctors this sensation? Do you feel heat? Are you hot at night? They may not say a flash. Different cultures describe things differently.
Right.
Yeah,
That's
so
very
your
interesting.
ethnicity, disclosing that to your doctor and hoping that your doctor has that understanding is so important, because you're going to direct us through, you've already directed us in so many ways to the right providers.
Right.
That will know that there's a difference. you know.
Absolutely.
So
All right, guys, we are going to take a little break right now to have a word from our sponsor.
Hey, New York. I'm Harvey, proud owner of Optics and veteran in the eyewear industry. Consider this. Why would someone have a closet full of shoes but only a few pair of glasses when eyewear is the only accessory that completely changes the way you look, feel, and the way you're perceived? At Optics, Cartier, Chanel, Dior, Lindbergh headline our extensive collection of luxury eyewear. Our opticians are trained to style and fit your face to ensure that when you leave Optics, your friends will be wondering where you shop.
Welcome back to Rebranding Menopause. We're here with the Dr. McNally, and we're super excited to have her here today. We are continuing from episode 7 into episode 8, and I think we're going to get into some testosterone talk.
Let's do it.
Could
Let's
you?
talk tea.
Yeah, let's
Talk tea.
So
Spill the tea.
I'd like to know, because I'm
Spill the tea on
hearing,
tea.
of course, you've always hear about men taking testosterone, right? And now I'm hearing a lot more women wanting to take a little bit of testosterone for their sex drive. Tell me, what do you think?
So,
And is it approved?
okay, so we always start with that. What's approved, what needs to be pushed, because again, what we have at current state versus what we need to are two separate conversations or an ongoing conversation. So for individuals that are going through any gender rechanges, there are testosterone that is being managed from a different point of medical care. For women, the Menopause Society has a position statement, kind of a guideline that helps us decide who should be on testosterone. And for hypoactive sexuality disorder, dysfunction, having 1/10 of the dose prescribed for male counterparts is something that could be very helpful for a specific subset of women.
Okay.
The asterisk goes up always, because that is what our current state is today.
And is that determined through blood work, I'm assuming?
So that's one of the things where blood work can be helpful, because in our bodies, estrogen, progesterone, and testosterone all decline when we're menopausal. So we don't want to get those testosterone levels too high into a range, because we don't have the data to say what long-term could happen from a cardiovascular status, but we also know there can be some irreversible voice deepening, hair changes that are more consistent with a male pattern.
Nobody wants that now.
Probably not for many women. So for what we're doing now is about relooking at hormone levels, testosterone, using this testosterone to libido. I think we need to be careful, because a testosterone cream at 1/10 of the dose prescribed for some of our male counterparts is not necessarily going to lead to this amazing sex life. Right. Because, and we can talk a little bit about the sexuality piece, but in general, the pendulum, I think, is swinging where there may be more use of testosterone in other aspects of hormone therapy. The other piece is in the clitoral region on the vulva. There are testosterone receptors that a local testosterone can be helpful.
A testosterone cream?
So right now, FDA has approved a medication that is DHEA. I know you're all scribbling this down. It can help with vaginal dryness, vaginal pains, discomfort, because DHEA is a derivative, a type of testosterone-like medication that gets converted in our body to estrogen and testosterone. And that has been shown to help sex.
Wasn't there a supplement, sorry to interrupt you, but wasn't
No.
there a supplement that was the same that they were giving that's supposed to help with cognition? why do I remember, or am I thinking of a different vitamin? I'm going to look it up, and I'm going to bring it next time. I have it in my house.
Yeah.
Because I get severe migraines, and there is family members that have gone through, early onset dementia.
Okay.
And there was a supplement that sounded like that.
Okay.
That they gave. It wasn't a cream. So I'm going to bring that.
Wait, so you're saying that there's a cream that's FDA approved?
It's a medication,
Okay.
or like a suppository.
Okay, a suppository.
So then it kind of helps coat the area.
I think also, if I'm not mistaken, not only is it a physical thing, but I think it's a mental thing too. You know, if you have a low libido, because think about some women are, if you're married and you have kids and you have a lot going on, you know, there's just a lot in your life. And if you're working, it's more than just that.
Correct.
But like you said in the last episode, there are things you can do just by connecting with your partner, maybe using a vibrator, maybe having more foreplay, maybe having a date night.
Step it up a little bit.
You need to remember that you have to step it up, and the effort that you used to put into having sex, like you used to have romantic dinner and you listen to music and dim the lights and put the candles on. When's the last time you lit a candle? You know what I'm saying? Like for me, that was my MO.
I'm running around the house trying to put them out because I'm afraid my kids are going to burn the house down. I don't want the candles on. It's true.
But and there's a difference between your biologic sex, your sexual act of how you are comfortable interacting with somebody, and your sexuality. And your sexuality is very complex. Like, how do you feel in your body?
Mm-hmm.
Right? Your skin is different. We talked about vaginal health. You have the menobelly. Like, I don't feel good.
Right.
The last thing I want to do is be intimate with my partner. And then do you have mood changes? Again, all those life stressors that are the priority.
Right.
There's Netflix, there's no chilling.
Exactly.
And that's okay, because we put so much pressure on this idea that sex, but that may not even be what's on your partner's mind, believe it or not.
Right.
You got to have that open communication, and that's your sexuality, how you communicate with your partner.
Right.
And it may be a much more collaborative conversation when you actually talk about it.
Mm-hmm. Yeah, I mean, especially I think some marriages, like that's just a big thing.
Right.
You know, like that's a really big part of your relationship. Mm-hmm. So when that starts to slow down, it's like, whoa, what's happening to the whole relationship? Right. And it's really nothing's happening. It's just maybe we got busy, maybe, life happened in the meantime.
Yeah, and relationships have seasons,
right.
You settle in. Right. And the one thing I think that I've been hearing a lot from, because now the conversation with the podcast, everywhere we go, somebody wants to talk about the podcast. And I'm hearing women stating that they feel if they had more testosterone, their sex life would be perfect, back to normal, their husbands would be happy, and I just need testosterone.
Yep.
And so I think that that's a really big point that we need to emphasize, that it's a very intricate, delicate part of this whole hormone replacement therapy, individualized plan.
And it's a dangerous piece.
It's not a coverall, a one size fits everyone.
That's if I could, one takeaway, that I hear women that their husbands are on testosterone because they're getting a little older. Now they're chasing them around the house because the husbands, it's affecting the men differently. And the women are like, well, maybe I'll just take a little from my friend. Maybe I'll take a little bit of his. And that is such a dangerous, to me, never take a pill or from someone else.
They're taking the husband's testosterone?
They want to take the husbands. They want to take their girlfriends. You've heard of this, right? I mean, because they think that testosterone, a little bit, is going to be the answer to making their relationship
that's not like
better.
taking a little
it's
Tylenol.
Yeah.
Listen.
You said something about for women who are getting an incorrect dose of testosterone, you could have hair pattern changes. Mm-hmm. So I always think back to...
You can grow a beard.
Well, so isn't that interesting?
Beard.
But wait, so stay with that. So Ingrid, so you're saying it's going to grow, but I think of like the guys that when we were all younger that were doing testosterone in the gym.
Right.
Their hair, didn't it fall out?
They had a hairy back.
So their hair falls out.
Yep.
Women take testosterone and their hair grows. So it's just like craziness.
Well, you'll
Correct.
see some hair here, right? In all the male places, you'll start getting like the women that have, hormonal
Right.
imbalances.
Correct.
Yes, we see it all the time for
Wow,
laser hair removal.
that's a lot to unpack.
Right.
But it's
'cause
a lot to understand. It's important to understand.
And it's not A leads to B.
Right.
It is really this Venn diagram of all these pieces, and testosterone may play a significant role for some women. It just needs to be on that list of what else, so we can make sure that this is the right next step. And there are some topical creams, some other things that can be done that will enhance your sex life.
Okay, so another question, and we're going to wrap this up, but I have one more question. So if you're talking to your gynecologist, I mean, I know I just like threw up on her about my sex life and everything. I didn't even know what she was going to do.
Not breaking HIPAA.
Get out.
But if you don't feel comfortable, like I felt comfortable with you, how do you go about talking
Yes.
to, especially if your gynecologist is a male, about your sex life? What can you do to bring up that subject about possibly having that testosterone?
So you just say it like you did, and that menopause quick 6 that we talked about has
Can you
pelvic
review
health.
that really quick right now, the menopause quick six?
So it is a cheat sheet of 6 questions in terms of mental health, pelvic health, including sexual dysfunction, period changes, hot flashes. So when you're looking at all of these things, sex is one of the parts to that pelvic health question. So you bring it up like that. The other piece, again, the complexity of it. If I told you, hey, I'm going to take this metal bat, you're going to stand there and I'm going to whack you 10 times. It's going to be amazing. You're not going to do it
Right.
because it's painful. And then you have that response being, please don't hit me with this bat. I'm never going to hit anybody with a bat. Just want to put that out there. But if you're in pain, why would you even do something?
Right.
So you can, if you're not comfortable talking about sex per se, I'm uncomfortable vaginally. And sometimes if the pain gets better, right, you have the vaginal hydration we've talked about, the local estrogen or testosterone derivatives if appropriate, all of these things, pelvic floor therapy, if the pain goes away, guess what? That pain libido bubble goes away,
Right.
and then there may be a change in that.
I've never heard sex compared to, like getting beat with a bat, but to
Well,
some
to
some
some
women,
people it
when it's
might
very,
be,
very
though.
painful.
It's very painful.
That's
Yeah,
the
I've heard
last
women
thing that
say
they
that.
want to
Correct.
do.
Yeah.
And listen, in all fairness, and I know we need to wrap it up, when intercourse is really painful, it can indicate something even worse in some cases, right, than just a hormone. You should always tell your doctor
Yes.
if you're in pain. That shouldn't happen.
And HRT really does hold off that painful sex. It keeps everything young, if you will. It keeps everything working. All of the systems are working, and you don't go through that. You may go through it a little bit. I'm not saying it completely gets rid of, the possibility that you might experience that. But that's one of the successes of HRT therapy, that you don't have those symptoms. So
To
if
the
it's right for
significant,
you,
right? Not
find
the
out.
significant way.
I'm sure it's different for every
Sure,
person.
100%.
Yeah, but find
Yeah.
out.
Yeah. And I think also, I know for me, I would never, I don't know why, it's just like a mental block. I would never say to my husband, like, oh, I'm having painful, I don't know why. It's like,
well, you'd run and try and treat it.
yeah,
because it's
before
an important
deal
part
with
of
it
your
on your
I
own
should be able to
first.
say anything. And I
Right.
can say anything to him.
Yeah.
But for me, it's almost like
Well, 'cause maybe he would then feel
it would
bad.
be a prideful thing, but I would never.
And
don't
it's
want
so
your partner to
common.
feel like
This
they're
is
hurting you.
Right. This is exactly what you guys are doing. Say it. It hurts.
Right.
Okay.
Right.
And I tell my patients, I may not bring you to a 4.0, but if I get you to like a 3.3, that's
Right,
amazing.
We're good.
Oh my God,
I'll take
yeah.
a 3.3.
Home run,
Sure. I'll take a B+.
Yes.
All right, guys. On that note, we are so thankful for you, Dr. McNally. And
What
we're-
an episode.
and we're having her back
Bearing it all.
again next week. So Mondays with McNally
Can't
will
wait.
continue.
Fantastic. Thank you.
Thank you.
If you're watching, please subscribe to get notifications for when our next podcast drops. And we thank you for watching.
Comment and like.
Comment and like.
Comment and
Comment and like. Thanks. Bye.
Hi friends, this is Dana Persico from Long Island Nail, Skin and Hair Institute. The Institute is not only the premier venue for licensing and certification for beauty professionals in Long Island as well as New York State. You can receive beauty treatments specifically for anti-aging, facials, body treatments, laser hair removal, hydrofacial. Our senior students are working in the spa. They are happy to get any of our guests ready for this special event located in Bethpage, New York at 1055 Stewart Avenue.